Didn't realize how much this tie blends in with this shirt.
Stylish.
Thank you. I try. Do my best.
We are live now.
Yeah.
Oh, thanks.
Delegate Young is only saying that because we both have all the same clothes and are about the same size. So,
But he did warn me he was wearing that today, so I didn't have the same.
all right. So as we are waiting for everyone to come into the Zoom, give it another minute. And then we will get started. All right. So we're going to go ahead and get started. I want to thank everyone for joining us today. This is the Health and Social Services Subcommittee on Appropriations. We have a single budget hearing today, though it's one of our bigger ones. It is the Behavioral Health Administration. As always, we get started with the report of the analyst. And then we will move to the department, and then we will move to the witnesses. Today we have about, excuse me, 6 or 7 witnesses representing various organizations signed up to testify. So we will take them in course. Just a reminder to everyone, this is being streamed live, as was pointed out when Delegate Young and I were commenting on each other's outfits. So anything that is said, shown, or messaged in the chat box is all being made live and subject to Public Information Act. So just something to be reminded of every time. We will go ahead and begin with Andrew Garrison, our DLS analyst, and his budget analysis. Andrew, go ahead and take it away.
Thank you, Chair Reisman. Good afternoon, members of the subcommittee. In front of you all, you should be now seeing the fiscal 23 budget for the Behavioral Health Administration. As the chair mentioned, this is a large budget here. We have about $2.5, almost $2.6 billion that we're talking about. And we're actually reflecting a decrease in the budget this year. And that's largely due to some deficiency appropriations that we're going to be talking about a little bit later on. But once we take those away, we kind of made those the dotted or the hashed portions of this. It's actually pretty flat funding from the 22 working into the 23 allowance. First, to kind of foreground the discussion of what we have here, a lot of the dollars that we're talking about relate specifically to the public behavioral health system, PBHS is how we're referring to it throughout here. And for provider reimbursements for folks getting services through that. So this is the Medicaid component, largely of specialty mental health services that we provide here in the state. And what we're showing on Exhibit 1 is in the data that's reported to DLS with the governor's allowance actually shows that the number of individuals who have been treated in the system have gone down in recent years. So since a high point in 2019, in 2020 and 2021, we're actually treating fewer individuals through the system, with particular decreasing in those who are duly diagnosed with co-occurring mental health or substance use disorders. And this is interesting because, of course, a lot of things happened from that 2019 period. First and foremost, there was a transition with the ASO in 2020. Additionally, obviously the COVID-19 pandemic has occurred during this period, which may have had some potential increases in need for mental health, but also might have had some challenges when it came to accessing treatment in certain settings. And then lastly, it is important to highlight that overall Medicaid enrollment has actually grown over this period. And this is in part due to certain provisions of the public health emergency in response to COVID have prevented the state from redetermining a lot of their enrollees. So our enrollments continue to grow, even though we're showing individuals actually being served going down. So taken in tandem, this kind of suggests that it's not that there's a decrease in need for especially mental health or substance use services, but rather that there's maybe some challenges accessing the public behavioral health system. Another thing we wanted to point out before getting into the budget section is that the share of individuals with mental health needs in the state who are actually being served by this system. This is actually a reporting measure that's been brought back by the department here in this MFR section. And what we're showing is that of individuals who need the specialty mental health service, 38% of them are getting treated through the public behavioral health system. And of children who need specialty mental health services, almost half of them are getting treated through the system. So what that kind of suggests is that the Medicaid population, the folks who are using these services, perhaps disproportionately have a greater mental health need than individuals who are insured either privately or through the other commercial insurers. Another aspect that we think is important to highlight is some of the performance measures and how care is actually being delivered in the system. And the department recently started reporting on readmission rates for inpatient mental health services or for substance use disorder residential treatment. And in 2021, I wanted to highlight that the number of folks receiving those inpatient treatments has gone down. And when you compare it to 2020, and that's of course due to probably some challenges in accessing services or maybe potential delay in inpatient care given the nature of the recent pandemic. However, particularly with substance use, the share of those who are readmitting has gone up, even though we have fewer individuals that are ultimately being treated through that service. And readmissions, of course, is within 30 days and something that's interested in tracking when it comes to the quality of care that's being provided through these more intensive inpatient or residential settings. Additionally, one encouraging performance measure that we have here is the department's actually routinely reported on telebehavioral health services, particularly in rural settings, as part of a partnership with some of the other mental health providers in the state, and looking at the share of folks who are accessing telebehavioral health services in a rural setting compared to those who are receiving just regular outpatient treatment. And of course, what we're seeing here is that in 2020 and then even continuing into fiscal 2021, the share of individuals who are receiving their behavioral health treatment through telehealth has significantly increased. Of course, we could point to some of this being related to the pandemic and being able to access care that way. But DLS is interested in if this is a broader trend in the public behavioral health system and throughout the state. And so we do have a recommendation for committee narrative around the prevalence of behavioral health services being delivered through telehealth, and adopting narrative to look at the statewide prevalence of that, not just in the rural settings, which has traditionally been reported on. The other thing to highlight from a care delivery standpoint is medically assisted treatment. This is something that's also provided to DLS with the budget through the MFR submissions. And the number of individuals receiving medically assisted treatment is usually something that's really important for opioid use disorder. We're talking about methadone or certain opiate and medication that makes it either that reduces the cravings for certain illicit substances. And we're seeing that the rate of those receiving medically assisted treatment is relatively consistent, right around 30%. That's relatively low. And so we are also having a recommendation around including committee narrative for the access to medically assisted treatment, where those providers are located in the state, and then any sort of other outcome-based measures that we can be looking at for those individuals who are receiving that treatment. Moving on to some of the dollars that we have in this budget here. First, it's important to note a lot of the fiscal 2022 deficiencies that were brought in. As I mentioned at the top, this really drives a lot of the change that we see in this budget, and the largest of which is for service year 2021. And so when the Behavioral Health Administration closed out their budget for fiscal 21, they didn't have enough money to accrue a balance to pay prior year services. So normally we would want 2021 services to be paid with 2021 dollars, but because there wasn't enough to accrue those dollars, they have to use 2022 dollars for that. And that's why they're getting this deficiency here, which is the largest of that. It's 111 million in general funds. And then the federal fund component of that brings us up to about $340 million in total funds that we're using $22 for to pay for those 21 services. We also have rate increases that were provided through through the deficiency for fiscal 2022. This is related to home and community-based services. It's about 65 million in the Medicaid component of this, and then the remaining part of it in the Medicaid and the non-Medicaid services. This actually reflects some double budgeted funds. The governor corrected a little bit of this in his supplemental, but DLS does have a recommendation to delete the other double budgeted funds that are coming into the Medicaid component of this. That's about a $65 million recommendation. We do also, the governor has a deficiency for for the enhanced federal fund match. That's a 21.5 million that we have there. Interestingly, when this deficiency came in, they didn't reduce any general funds from that. However, again, this was also addressed in the supplemental, where the supplemental came in for the final quarter of this enhanced federal fund match. This represents the third quarter. We've since learned that we're going to be getting a fourth quarter of that. And the governor did take out the general fund component on that end. For the last component of this, we do also have an aspect of this $13 million in general funds to address the ASO, which we'll be talking about quite a bit later. And then I'd also like to highlight that this Easter Seals grant will continue into fiscal 23 as well. The other aspect of this, as I mentioned, is there's a lot of dollars associated with the home and community-based services rate increase. This is a provision of ARPA that included a 10% enhanced federal fund match for certain services for home and community-based services. Again, this is estimated at around 65 million for this budget in fiscals 2022 and 2023. There is a component of this that needs to be state dollars. So we are asking the department to comment on the availability of state funds for this, particularly given some of the adequacy concerns that we address later on in this budget. What we're currently reflecting, and of course, as you all know, is a lot of the dollars that we have here is related to those provider reimbursements. That makes up about almost 90% of this budget. We have the components that are getting a Medicaid match. And then we also, as the state of Maryland, are providing additional services that aren't necessarily Medicaid eligible that are largely funded with general funds or other state dollars that we have access to. This includes particular room and board at substance use treatment disorder, substance use treatment residential, or staying longer at some of those facilities. And until very recently, inpatient mental health services at Institutes for Mental Disease were also needing to be entirely generally funded. And so of that remaining 11% that we have that's not fee for service, we actually show a lot of that is still going to provision of either grants or programs still to do care for those who with mental health or substance use needs. Only about 15% of this little pie here, about 45 million of that is towards what we would call really just administrative expenses. So either the personnel for the folks working at BHA or the contract for the ASO is valued at 26 million in the fiscal 23 allowance. Looking at some of the change really quickly, a lot of that change is, of course, coming in those fee-for-service categories, given that that does make up such a significant share of this budget. We have about 50 million in new funding coming in. This actually includes a restoration of a general fund cut last year related to that enhanced federal fund match. That's about 35 million increase. Also, there is new funding available reflected in this budget from the recoupment of overpayments. It is coming in at $100 million in special funds. DLS has been advised that once those dollars come in, they'll be able to then go back out to pay provider reimbursements. And so we're rolling that in here as new dollars as well. And then we're also offsetting this against some of the deficiency decreases that we saw previously. We do pull out those fiscal year 2021 deficiency amounts as separate and under the fee-for-service category, and also the provider rate increases under Chapter 11 of 2019, the Fight for 15 bill are funded at, again, about almost $50 million. On the programmatic side, that kind of non-fee-for-service spending, there's funding for the implementation of Chapter 785 of 2021, the matching fund grant for service members of veterans. That's 2.5 million reflecting this budget. And then also we do have some federal grants and that are rolled into here. 2 federal block grants have actually received increased funding from federal enhancements that's been authorized under some of the COVID Relief Act stuff. And then also the state has received significant funding from the state opioid response grants, and we're starting to see those kind of taper down in the budget. And so what we do in Exhibit 10 is we reflect some of the changes in those federal dollars by either mental health or substance use disorder purposes. As you see, the SOAR funding was a significant source of funding that we've seen over the last couple of years, particularly for substance use, and that is starting to decrease in the allowances currently reflected. Additionally, those enhancements, those block grants I mentioned, the community mental health block grant and the substance abuse prevention and treatment block grants have been added in 21, 22, and 23. We actually expect a little bit more federal money to be coming in into this budget. So we do ask the department to comment on the availability of those federal funds. We would expect it from both the block grant enhancements, again, authorized under some federal legislation, as well as perhaps some additional SOAR money that might still be outstanding. So getting into the forecast of this budget, this is particularly challenging every year for my office and for DDM, but this year was no exception, with a lot of different factors going into where we think that the funding needs are for this budget. And so we present that in Exhibit 11 here. First off, really just the starting point is something that's difficult to really calculate, given some of the challenges that we've had with data in recent years. So if we start with the data report that we receive currently, we come up with a lower number than if we go all the way back to 2019 and build off the rates there. So those are the high and low columns just off the bat. Again, you know, as you all know, there's maybe been some concerns around the data that's being provided currently. And so, you know, jumping off of that gives us a lower dollar amount. That's that 621 there. And then from there, depending on how much utilization we want to maybe add, you know, that further impacts the potential need. We do believe that there might be some state dollars need to be committed to the home community-based services rate increases, which produces further need. There's also some savings, of course, that are not yet reflected in this budget, and we're accounting for all of that. And we have some adequacy concerns with all those considerations for fiscal 2022. And then into 2023, we still have some of the same concerns and challenges as to what should be the jumping off point, where utilization might go with this budget. But in particular, what really drives any adequacy concerns that may exist in 23 is how much of those special funds are available to be used for provider reimbursements, how much is getting recouped, and then being able to go back out to pay for some of those provider reimbursements. If all $100 million is available, there's certainly more than enough state funds available in this budget. However, if that is not necessarily recouped, we have some significant adequacy concerns just looking at the general funds that are available alone. But you know, there are certainly a lot of error bars here, and because of that, we do have a recommendation to restrict the funding that's currently appropriated in the provider reimbursement categories to just be able to be used for provider reimbursements and between those other categories. So the Medicaid dollars can only be used for Medicaid, or some of those Medicaid assistance dollars, and vice versa. And this is just a quick visualization of kind of what those error bars look like for us. Again, broadly, we're more concerned about 2022 adequacy, with us being, if not close to, I guess, breaking even or below. But in 2023, really the factor there is how much of those provider reimbursement, recoupment dollars are available to go back out as provider reimbursements. Really does raise substantial adequacy concerns that we have here. Speaking of the recoupment process, that is the first issue that we present to you all is the ASO. And so as you all know, but I guess a quick refresher, the new ASO took over in calendar 2020. Right away, it was not able to process claims. And so the department had to do an estimated payment process that was based on service year 2019 claims. And those were just issued kind of on a weekly basis to keep providers afloat while the system was working out its kinks. Of course, as we know, calendar 2020, later, just a few short months after that, had the onset of the COVID-19 pandemic. And so what happened was a lot of these estimated payments were going out during a perhaps unnatural service environment for a lot of our providers. And so that created a discrepancy between what was ultimately services that were provided during that period and what was paid out, because what was paid out was based on 2019. And so now there's a delta between the estimated payments that were provided that ended up going through August of 2020 and the services that were actually provided during that period and the claims that were processed subsequently. Even though the ASO wasn't necessarily processing claims during that period, the providers were still submitting claims for the work that they were doing during that estimated payment period. And so in attempts to reconcile that, the department has now reported about a $214.5 million difference between claims that were submitted during that period or claims accepted and processed for services during that period and what was paid out through the estimated payment system. And so with that in mind, what we've plotted here is the sort of cumulative impact of that. And you see that there really is a distributional concern with who owes the department what under this current system. And so a relatively small number of providers, about 10% of them owe about 75% of the total dollars. That's that 246 that we see there. We're talking about a universe of about 2,600 or so providers that we have in the public behavioral health system. And if we go up to get 90% of the total amount outstanding, 193 million, we're talking about only 530 providers. Again, we're looking at maybe 20% of kind of the total pool, representing about 90% of the total pot. Again, just kind of given the distribution of the size of providers that we have in the system. And what we wanted to use as a unit for analysis for this, and I should note that this is the 250 number for amount owed is current as of February 2nd of this year from a report provided to us by the department. And so what we wanted to do is we wanted to analyze them based on how much percent complete is kind of the unit of measurement we're using here. And what this is reflecting is how much of the claims that they had submitted during that period was able to pay off their balance owed of those estimated payments. So someone who has a 0% complete did not submit a single claim during that estimated payment period, that 8-month period. And someone who had 100% complete submitted enough claims to make up the entirety of their estimated payment balance. And so we have a couple different interesting things that we're showing in Exhibit 14 as to how this is distributed. One, we see the largest number of providers are on either tail of that. They either did not submit a single claim or they've submitted enough claims to take to match services in fiscal 19. And however, interestingly, the dollars associated with them are relatively small. It of course makes sense for people who have 100% complete to not have any dollars associated with them. But the folks who did not pay anything relatively only have a small dollar amount outstanding associated with those providers. It's about $10 million. Where we really see a lot of these dollars concentrated is in the 60 to 90% range. And so what that likely represents is a provider who was still operating during the pandemic, but perhaps operating with a lower volume or lower utilization than they would have otherwise. Or they were a provider who received a relatively large dollar amount from the estimated payments because they were doing a high cost service. One particular instance of this could theoretically be if you were having a residential treatment services. We know that residential treatment really decreased during the pandemic for obvious reasons. People were reticent to go into congregate living facilities due to the nature of the crisis, and residential services get reimbursed at a really high rate. So if you're getting paid off of services in 2019 and you weren't able to do a fraction of those, that really creates that discrepancy that we're starting to see here in the amount that's owed. The department has so far reported that they want to extend forgiveness to providers who owe less than $10,000 collectively. And that actually includes paying back providers who have already paid them for the amount difference if that amount has been under $10,000. And from that, they're excluding individuals who did not pay anything, so who had no claims, those no offset providers. And so we've plotted here where that current forgiveness group represents in terms of the number of providers associated with that and the amounts owed by, again, using percent complete as that unit of measurement. And again, we kind of see the same trend where we have more of a concentration of the dollars in folks who are likely operating, but just operating at a lower utilization or service rate than they would have otherwise. This is just for those folks under $10,000, which based on the data we received, DLS estimates is about 3 to 3.5 million worth for funding needed to issue that forgiveness. As I mentioned a little bit earlier, there's a $13 million deficiency associated with the issues related to the ASO. And so by our estimation, there's about 10 million left that could be used for some other type of either provider forgiveness or provider reimbursements. For instance, we looked at if the forgiveness was extended to providers up to $25,000, that would only take about another $5 million, and it would clear about another 300 providers of any amounts owed to the department. Again, kind of working from the tail of that earlier distribution that we showed. And so with that in mind, we have a couple of areas for the department to comment. First, the department noted that the 10 million that's left after we take that the 3 million away to cover those folks under $10,000 is used for folks that they already sent to collections, that 10 million for the no offset providers. If those folks are already sent to collections, we would expect those money to be coming back eventually. And so we're, I guess, a little confused as to why we need to be supporting that with general funds at present. So we are asking the department to comment on the planned use of that funding, given that they're already sort of off to collections and off the books. Additionally, when it comes to forgiveness, we noted that the current deficiency related to this says issues related to the ASO. So DLS has a couple of recommendations around there. First, budget bill language being a little bit more specific around what those funding should be used for, particularly for provider forgiveness. And also we want to specify that for maybe small dollar providers up to or less than rather $250,000 or $25,000 or being able to use it for provider reimbursements. As we noted, we do have some adequacy concerns in fiscal 2022. So being able to use some of those extra dollars that might not be needed after they do their $10,000 forgiveness plan could be used to cover some of the adequacy concerns that we have there. Further, DLS has a separate recommendation around budget bill language, restricting funding pending a report on what the use of that deficiency dollars were, particularly as it relates to any sort of forgiveness program, again, with that $13 million that came in through the deficiency. The other thing to highlight in this budget, of course, is some of the trends that we've seen in mental and substance use needs in the state. And so first, in Exhibit 16, we present some federal data that suggests some of the highest rates in drug overdose deaths that we've seen in the state in recent years. And particularly, we also can see that a lot of those are associated, of course, with opioids. Looking at data from the Opioid Operational Command Center, the OCC, to get a little bit more into specifics of the Maryland regions, we consistently see a lot of those concentrated in Baltimore City. And we increasingly see fentanyl being related to a lot of these drug overdose deaths. Of course, opioids are related to 90%, as we showed previously, but really the prevalence of fentanyl as that primary opioid in these fatalities is overwhelming other substances and other opioids that we have in the state when it comes to those fatalities. Additionally, DLS was important to highlight perhaps the rising mental health need in the state. And this has been a concern on the federal level. The CDC and the Surgeon General have released a lot of reporting and information on growing mental health concerns. So this is looking at a CDC report that was issued that compared the emergency department visits for suspected suicide attempts, particularly for adolescents, so those aged 12 to 17, and comparing them to a 2019 period. And unfortunately, what we're seeing is an increase in that for all groups, but really driven by adolescent girls with substantial increases over those 2019 benchmarks and up to over 60% in the winter months. This is also true. A separate CDC report looked at mental health ED visits also being on the rise again for a young adult and youth population. Relatedly, federal data supports or shows suicide fatalities increasing in Maryland, particularly in the last quarter of 2021 here. We see an increase in that most recent rate, that immediate rate for the 3 months ending there, which is actually running counter to the national trends. It is important to highlight that, of course, Maryland is traditionally lower than the nation when it comes to suicide fatalities. And of course, that even ED visits related to mental health or suicide fatalities are not necessarily the cause of any one particular factor or instance, but really perhaps pointing to a growing mental health need that we're seeing in the state. We do also, of course, experience some lagging difficulties with this data. So this is, we've still yet to see what the longer tail of the pandemic may be on Marylanders, but certainly is a troubling sign. And for more current data, we've used the call volumes to a crisis line from Behavioral Health Systems Baltimore, their Here to Help hotline. Unsurprisingly, of course, calls to this crisis center spiked in the early phases of the pandemic, but they've remained elevated, in fact, being as high as they've ever been since we've been looking at this data as recently as September of 2021. There's been some JCR reporting that you all asked for last year, particularly as it relates to crisis services. Two come to mind. One would be the request around the Greater Baltimore Regional Integrated Crisis System, the GBRIC system, as well as the 988 funding, or the 988 hotline. Recent federal legislation has mandated the suicide crisis line to be directed through 988. And so we would expect not only is there perhaps a need for mental health services, but also the demand might increase due to this transition at the federal level for 988. And so we are asking the department to comment on these outstanding JCR reports. That does conclude my presentation, and I'd be happy to take any questions.
Thank you, Andrew. Are there any Delegate Valentino Smith?
Thank you, Mr. Chairman. Not so much in the form of a question, but I thought it was important given the work that was done on this budget. All of our analysts do a good job, but I really want to congratulate Mr. Garrison on the significant amount of work that was put into this. He brought forth MFRs and kept us up to date on those and really gave us significant amount of information on the Optum and the ASO provider agreement, as well as raising some of the major issues that we need to think about as a subcommittee with respect to the department and the social issues of suicide and drug abuse. And so just an excellent report. Thank you, Mr. Garrison.
All right. I think we can all agree on that one. All right, now we're going to turn to the department. We have with us the Secretary of the Department of Health and his team. Mr. Secretary, if you would be so kind as to introduce who's with you and then provide the department's response. We'd appreciate that.
Thank you, Chair Resnick. I have with me our Deputy Secretary for Behavioral Health, Dr. Jones. I also have our CFO, Emily Brandenburg, and the Behavioral Health Director of Finance, Marian Katsarelis, and Linda Riddleman, who oversees the Medicaid ASO project, our Budget Director, Nick Napolitano, and Assistant Secretary Yee. And for the record, my name is Dennis Schrader, Secretary of Health. We want to thank the analyst for his report. It was very thorough and very helpful, so we thank him for that. Mr. Chair, Vice Chair, and members of the committee, I'm going to turn it over to Dr. Jones to respond to the analysts' questions, and some of those will also be taken by our CFO, Emily Brandenburg. Dr. Jones?
Thank you, Secretary Schrader. As Secretary Schrader has mentioned, we thank the Governor, the Department of Budget and Management, and the Budget Committees for their support in 2020 and 2021 with the COVID-19 response efforts. We thank the Department of Legislative Services for its insightful budget analysis. First question or statement: given the known prevalence of telebehavioral health services in rural parts of Maryland and the presumed importance that these services offer in expanding access to mental health treatment throughout the state, DLS recommends adopting committee narrative that requests BHA include data on the statewide prevalence of telebehavioral health services with future MFR submissions. With regards to our response, we respectfully disagree, as the Behavioral Health Administration nor the Behavioral Health Behavioral Health Maryland, we don't have access to the entire universe of telebehavioral health services in Maryland, so we can't gather statewide prevalence of these services. However, the Behavioral Health Administration can include this data that we do collect on the public behavioral health system. Additionally, the Maryland Healthcare Commission has begun a comprehensive telehealth study based on HB 123 and SB 3 in last year's legislation. This study may have more complete data than the department can provide at this time, as it will likely look at not only the public behavioral health system, but all the healthcare system in general. You can see the MHCC site for additional information. Number two, DLS recommends adopting committee narrative requesting a report from the Behavioral Health Administration on the availability and barriers to access for medication-assisted treatment. This report should also include data on the distribution of MAT providers throughout the state and include outcome-based performance measures for MAT. The department concurs, but we do ask a due date of December 1st, 2022, as opposed to the October due date. DLS recommends deleting double budgeted and mistakenly budgeted federal funds provided through the fiscal 2022 deficiency and the federal funds mistakenly carrying through fiscal 2023 and M00L0102 and M001L01.3. However, DLS recommends maintaining the fiscal 2023 federal funds, as mentioned, to allow for spending authority of the rate increases into fiscal 2023. The department concurs with this recommendation. Please do note that the supplemental budget number 1 addresses this issue by providing general funds to support HCBS rate increases or home and community-based services rate increases within the 2 Behavioral Health Administration programs. Next statement, given DLS's concerns with general fund adequacy discussed later in this analysis, the department should comment on the availability of new state funds to support the enhancement of HCBS and the associated rate increases. Our response, the state funds are generated through the reinvestment of the 10% FMAP, and new state dollars will indeed be required to maintain the rate increase and peer recovery support services starting April 1st, 2024. Until then, the enhanced federal dollars will be reinvested back into the program and used to support the general fund share. States are only prohibited from using the enhanced funds to supplant any activities that started before April 1st, 2021. And we included a link to our latest proposed spending plan. MDH should comment on the availability of additional block grant funding not yet reflected in the 2023 allowance. Our response, the Behavioral Health Administration is awaiting notification from SAMHSA on another state opioid response grant award. We expect the federal government to provide updates soon. However, they have not been released as of yet. Next statement, given the wide range of general fund adequacy, including potential surpluses, DLS recommends adding budget bill language to restrict the use of provider reimbursements in the behavioral health budget to that purpose, including funds provided via deficiency appropriation. The department concurs. The department should comment on the planned use of this funding. DLS anticipates $10 million in this budget for further forgiveness, no offset provider funding collection, given that no offset providers have had collections already pursued against them. The department anticipates using the remaining $10 million deficiency for 3 purposes. Number 1, to repay providers owing less than $10,000 for any recoupment they made. Number 2, to account for unsuccessful collection from no offset providers. And lastly, to account for any future decisions made by the governor around provider forgiveness. It says that the funds were only provided for the purpose of forgiveness. DLS recommends adding budget bill language that restricts the $13 million in general fund deficiency. Our response to that statement is that the department respectfully does not agree with this recommendation. MGH supports the governor's budget, and we are happy to provide the requested report. And lastly, the budget committees were interested in the impact of the implementation regarding the JCR request for about the 988 implementation and the GBRICS project. The department is steadily working on these reports, and we intend to submit them as soon as possible. Do you have any?
Mr. Chairman, I think that concludes our reporting, and we're here to take questions, sir.
Thank you. Are there any questions for the department? Daryl Valentino Smith.
Thank you, Mr. Chairman. And I know that, Mr. Secretary, we have a hearing coming up next week on the Optum issue, but I just want to take this opportunity with respect to the budget issues to clarify a couple of things, Mr. Chairman, just a little leeway here with some questions. What does, we haven't figured this out yet. What does Optum submit to you, to the department, in order to receive reimbursement? What basis, what documentation, what data with respect to claims processing? What do you get from Optum under the contract to decide how much money to send them?
Yes, like any contractor in the state system, there are contract monitors, and they submit invoices against the contract, and we're paid in accordance with the terms and conditions in the contract.
So you have somebody monitoring your invoices, okay? On
Correct.
January 31st, you sent to us in the Appropriations Committee a follow-up to the JCR. And you said that, so this is January 31st, it was like 28 days ago. I don't like to do math out loud, but like 28 days ago. You submitted to us in the Appropriations Committee that you did a recent audit by the MDH Office of Internal Controls and Audit Compliance. And you found that some of Optum's systems continue to be deficient and require stabilization. And as a result of your testing, you asked Optum to submit test results to you by January 28th with a plan of correction and all other risk assessments going forward. So before you answer, I just want to correct that as of 28 days ago, you were recognizing that there were system deficiencies and a need of significant stabilization for which you still were requiring corrective action from Optum. Then you said to us that Optum had 4 contract management tools, or tools upon which you decide whether they're meeting their contract. And you said it's service level agreements. This is for if they're in breach, they have to meet service level agreements. So service level agreements are contract terms that require Optum to meet certain requirements: customer service responses, system availability, staffing, and claims processing. So you have required the vendor and in your monitorance of the contract to have service level agreements. And you told us 28 days ago that since the contract started, which is January 2020, that you've withheld only 4% of the invoices because they've failed to meet 11 of the 12 service agreements. And the only service agreement that they met was having the requisite number of staffing. And so you withheld $1.3 million. So you were telling us 28 days ago that they had sufficient deficiencies, they required stabilization, and that they only met one of the service requirements in the contract that they have with you, which was staffing requirements. And that they failed to deliver and have failed to deliver a comprehensive reporting system to you. And that then you withheld $4 million because of their failure to deliver critical claims adjudication, including 835 forms, consolidated claims history reports, and other data. So 28 days ago, we continued to have you affirming for us that they were not meeting their contractual requirements with you. So Mr. Garrison just told us there's $215 million about right now at issue. And one of two things with the $215 million, either services were never provided and the providers collected, the estimated payments, or services were provided. And this deficient system that only meets one of the 12 requirements is unable to figure out whether services were actually were rendered. And if they were rendered, we would be getting federal matching money. So the $215 million, one of two buckets. It either was never rendered, and the providers have said if they didn't render the care, they have no intention or had no intention of keeping the money, but that they have rendered the care, they have submitted claims, and that you're telling us the system is deficient and unable to adjudicate the claims. So we are losing matching federal money. And we as a state, as an appropriations committee or an HGO committee, how do you expect to figure out whether the $215 million was for care rendered or for an appropriation that needs to be reconciled with the providers? Because we can't trust what Optum's saying, given the report you just gave us.
Thank you, Madam Vice Chair. So let me back up the system has been operational since August of 2020, and we have been paying the claims. What we should differentiate is how are we reconciling what happened in the estimated payments periods from January to August of 2020, and that's the focus of the $215 million. Secondarily, is we have been continuing to press the contractor to deliver all of the features and functions that we expected. So those are two different issues. The $250 million started out as $390 million, and we have been working that down from $390 to $215 million. And last week, the claims history for all the vendors was delivered, albeit I'm not happy with the time it took, but they did deliver it, and the providers now have the claims history. Linda Riddleman, who's on the call with us today, can give more detail about that. But we are insisting that we continue to drive the implementation of this project. But the fact of the matter is that the providers are being paid, and what we are talking about is really for the period from January to August of 2020. Linda, did you want to add anything to that, or did I miss anything?
No, you didn't miss anything. I think it's important to note that yes, we started with a difference of 390, and we're down, significantly, almost 80% or more than 80% of those. That difference has been reclaimed. That came through the submission of claims, even though we were paying them estimated claims because the system was not able to process claims. Providers kept submitting claims for services actually rendered during that period of time. And then we matched those up, or Optum matched those up against the estimated payments. So what you're seeing is the delta between actual services and claims submitted and what hasn't been. And to Secretary Schrader's point, last week, they delivered a complete life cycle claims report that I know Delegate Resnick was very interested in getting out the door. And our early feedback from providers is that it's very helpful. I'm sure there'll be some tweaking that needs to be done. But that gives the provider a complete history of each claim they submitted during that period, from the submission of the claim to the full adjudication of the claim, denials, retractions, resubmissions, reprocessing, you name it. They're going through that data now. That should give them a much, much clearer, if not complete, view into exactly what is owed and where they stand. So, but we have made significant progress, and I'll let Secretary Schrader speak to the contractual issues.
Right. So for the service level agreements, we have been withholding money at a certain level, but that's based on the SLAs, and we have been routinely withholding dollars in alignment with the service level agreements.
So if you could, thank you. It's encouraging. Each meeting and briefing that we've had with you, and I have gone back and looked at them all because I want to be accurate. You have told us with great optimism what you think the fix is, and that the fix is coming relatively soon. And so I appreciate your level of optimism, but certainly it's been going on since November with when you thought they'd do things. So what I'd ask in leaving this hearing is that you did say to us that Optum was to provide you and your internal controls and audit compliance with a report about the risk assessments. And I'd like to see your assessment of that report that you were supposed to get January 28th. And then I think we'd like to see the total amount of money that you've withheld on the contract with Optum for their inability to meet 11 of the 12 SLAs. And then what you think now of the $215 million that's outstanding, the time frame is upon which you'll believe the reconciliation will be completed so that we have a better figure on what's at dispute for care that was never rendered or care that was rendered and continues to be in dispute. And then we'll know the estimated amount of federal money that we may then be able to avail ourselves of. So thank you. Thank you, Mr. Chairman.
Thank you. Any additional questions? Seeing none, I have a couple, if I may. Mr. Secretary, Ms. Riddleman, you mentioned the comprehensive report that has now gone out that you all mentioned to me, I believe about 2 weeks ago was going to happen. You said that it's being positively received. We will have about 6 providers on this call testify in a few minutes, and we'll find out how well it's being received from their perspective. So I have a couple questions. First, on that particular reporting tool, have they all gone out? Have every provider with whom you are seeking some sort of a reimbursement, whether it's from the reconciliation or the double payments or whatever other pockets of or pools of money that we are in this, we are talking about, have all of the reconciliation, all of the reporting gone out to back up the invoicing that is being made? That's my first question.
Yes, I can answer that for you, Delegate Resnick. We sent out a survey to providers asking them if they agreed with the amount shown that we for the estimated payment balance and some other buckets of negative balance, whether they disagreed with the amount and whether they would like a copy of the claims history report. They can request it. There's a large banner on the website now where they can just click on that and request the report. It can be turned around in 3 to 5 business days. Initially completing that survey, more than 600 providers requested that survey, that they did want it, and they wanted to receive it on a monthly basis for the most part. More than 2/3 of them want to keep getting it every month. Those reports, that initial reports, if they have requested a report to date, they have all been delivered. Yes.
So I'm going to ask the same question as a follow-up that I asked to Mr. Burkholder as well. Why do they need to request it? If you are invoicing somebody for a reimbursement, why can you not just send them the report as part of the request without having them have to go through the rigmarole of figuring out whether the number is correct, get back to you, get the report in a week later, and keep this schadenfreude going? Why can't you just send them the reports?
I don't want to speak for Optum, but I believe it was a resource issue on their part, but I can certainly bring that up as a request on your end.
Again, as I mentioned to Mr. Burkholder when I made that initial comment, we are talking about hundreds of small nonprofit organizations that are surviving on the skin of their teeth versus a multi-billion-dollar insurance company. And they're the ones with the resource problem. I would really like for you to just send them out, please. Okay. My second question, Mr. Secretary, you had mentioned that all requested payments since the reconciliation have been going out and all invoices have been met. Just 9 days ago, I received an email from a provider, a mental health provider in Aberdeen, who said, quote, after 2 years of underpayments and increased costs arising from Optum's dysfunction, we will be unable to make payroll within 2 to 3 weeks unless Optum begins to make substantial progress on paying these outstanding claims, which are either unpaid or improperly denied. We have already begun selling off assets and will initiate staff layoffs and service reductions unless we are able to receive outstanding payments within the next 10 days. I forwarded that email to Mr. Burkholder immediately. He promised me that they would take care of it, and I don't know that they did, but that goes contrary to the understanding that all legitimate invoices are being paid as of right now. So can you please comment on that?
Yes, I can, Delegate Resnick. I reached out to that provider personally and have had some lovely conversations with him over the last week and a half. We're meeting next week, and he's quite satisfied with the solutions that we came up with to solve his problems. We're going to send him some special reports. We've addressed his concerns about his payment plan and how those monies will be recouped. And he's working with us and has been very gracious about it. So he's fine now that he's getting some attention, and I did that myself.
Well, I'm glad to hear that. So does that mean that moving forward, I need to ask Mr. Martin and Ms. Doyle and Mr. Rabbit and all the others to send me every individual case of underpayment, and then I have to send you every individual case of underpayment so we can reach out individually to each one of these people?
Well, we do a lot of provider outreach as a matter of course. There is some disagreement. Part of the process with this particular provider is provider education, because a number of the claims that he would like to see reimbursed were improperly submitted, and we need to do some provider education with him for authorizations, for codes, for credentialing. There's a variety of reasons, and we've identified all of those, and we're going to be working with him on a one-on-one basis.
Okay. Thank you. Any other questions? Okay, seeing none, we will now go to public testimony. Let me pull up my list. Excuse you all, give me a minute. And I lost my list. I should really start printing these things out instead of keeping them on my email. So give me 1 second. There we go. All right, so at this point, we're gonna have, like I said, I believe we have 6 or 7 witnesses. Just for the sake of doing this on Zoom, we're going to go one at a time, but I would like for the committee or the subcommittee to save questions until all 7 people have had an opportunity to testify and treat them all as one panel if we can do that. So we're going to start with Ms. Lori Doyle from CBH.
Thanks, Mr. Chairman, members of the committee. Lori Doyle here on behalf of the Community Behavioral Health Association of Maryland, in support of the BHA budget, and in particular the 3.25% rate increase, which hopefully will help us offset some of our workforce crisis that we had prior to the pandemic and has only been exacerbated since. So we thank the governor for putting it in his budget, and we hope that you will allow that to remain in the budget. My remarks are really focused today on this whole issue of debt forgiveness and recoupment. The question is indeed, as Delegate Geraldine Valentino-Smith made, what is it that we owe? I attached to my testimony a couple of PowerPoint sheets that might help visualize this issue. The first is titled Reconciliation and Accountability. So what we have is a dispute about the amount that we owe, and it is tied up in these claims that are still sitting in Optum's system since January to August of 2020. What we're seeing is claims that were retracted in error or not paid to begin with, and or lost in their system. And so if those are not credited to what providers owe, it inflates the amount of what we owe. And that's where the discrepancy is. The other sheet that I've provided is really what we have proposed as a solution to this problem. And it's Reconciliation Cbh Proposal. Some of you have seen this before. So what it says is that providers will pay back all duplicate payments, and anything that Optum paid twice, we pay back. We understand we need to pay that back. There's no dispute from the state or from us. That Optum in turn pays all those claims that are either sitting in their system or lost to their system, erroneously denied, they pay them all or credit our account for them all. And that the difference then that's left is what providers received in estimated payments and what we were able to submit for services rendered. And we expect that there will be some difference, mostly due to COVID and the downturn in services at that time. We've surveyed our members recently to find out what we think the amount owed is. And we're seeing that the average forgiveness amount is about $28,000. Our data actually indicates that anywhere between 2/3 and 3/4 of the stated recoupment amount, what the state says we owe, is offset by claims that are sitting in their system. So this is really important that we get it right. We also believe that whatever forgiveness amount is granted, if any, that it should be given across the board regardless of provider size or the amount owed. So as an example, you forgive, let's just say $30,000 across the board. If a provider owes less, it will wipe out their debt. If they owe more, it will be deducted from the amount they owe. And the reason is that all providers were hit, large or small, by both COVID and Optum. The razor thin margins are the same, whether you're small or large, whether you provide a few services or a few thousand. And in reality, service mix actually provides a greater impact than size in terms of how you were hit. So if you did a lot of residential services, you got hit pretty hard. So the final thing I'll say is that if you look at the top of page 24 on Mr. Garrison's analysis, he did a really great job of encapsulating this whole period of chaos that we've been under for the past 2+ years. But if I did the math right, his analysis suggests that there are about 1,360 providers owing over $3,000. And that's without Optum having processed those claims that are sitting in their system. So likely that number will come down if they do so. So the impact of debt forgiveness is liable to be much smaller than what the state is portraying. You know, we think that this forgiveness is a very worthwhile one-time spend of the 2022 budget surplus to ensure that we still have services at a time of spiking need, and certainly the indicators are not good. We're happy to work with the committee on a reasonable solution, and we thank you for your time and attention.
Thank you. Next, we'll move to Dan Martin of the Mental Health Association of Maryland.
Thank you, Mr. Chair, members of the committee. Dan Martin with the Mental Health Association of Maryland, which is a consumer education and advocacy organization concerned with all aspects of mental health and mental illness. And I'm going to broaden the conversation a little bit beyond Optum, just to kind of give a broader view of why this is so frustrating that we're dealing with this at this time. The need coming out of this pandemic for mental health and substance use services is higher than we've ever seen it before. Nearly 40% of Marylanders reported symptoms of anxiety or depression last year, and yet nearly a third of those were unable to get counseling or therapy. Over 45% of Maryland youth aged 12 to 17 who reported symptoms of depression didn't receive any mental health care. Nearly 3,000 Marylanders died from drug overdose. Another 650 lost their lives to suicide. And 16 entire counties in our state have been federally designated as mental health professional shortage areas. Unfortunately, Maryland is in a relatively good financial position right now, relatively speaking. And so, we're making a lot of requests this year. And I want to start with this background because I have a few requests that we're going to make from the Mental Health Association and that we've made in our written testimony. And I guess my overall question is, given our financial position, if we're not going to invest in beefing up our systems now, then when will we ever do this? First I'll start a few specific requests. Please support full funding for the Behavioral Health Administration. They are doing great work right now. And again, given this need, a well-funded and fully functioning BHA is important now more than ever. Please support passage of the Behavioral Health System Modernization Act, which is jointly assigned to appropriations. That hearing will be in the House in a couple of weeks. Like the blueprint did for education, this bill will enact a series of reforms and enhancements to bring Maryland's behavioral health system into the 21st century. And you have some more details about that in my written testimony. Please support supplemental funding for dedicated staffing at the Behavioral Health Administration to coordinate and implement a 5-year plan to address the cognitive and behavioral health needs of Maryland's growing older adult population, which is something this committee raised up last year through the adoption of budget language requiring some initial reporting in this area. Please adopt language or narrative directing reviews of Maryland's process for screening individuals referred for placement in nursing homes to ensure the appropriateness of those placements, and for Maryland's system of prevention and early intervention programming for youth with behavioral health needs, and to identify whether there are other innovative processes going on throughout this country that we should be emulating. And lastly, like you just heard from Ms. Doyle, and that I'm sure you'll hear from some of our other partners, please support forgiveness for community behavioral health providers who, in the midst of this behavioral health crisis like we've never known, face the prospect of paying back large, unverified sums of money resulting from IT dysfunctions not of their making. And lastly, please support, that I'm sure you'll hear from Mr. Rabbit later on, please support an initial allocation of funding for Maryland's 988 implementation efforts. Again, all of these things are things that the Mental Health Association and all of our partners in the Behavioral Health Coalition, which is upwards of 100 nonprofit organizations right now around the state, have been raising up and identifying as kind of really things that we need to be investing in our state to bring us out of this crisis. And like I said, bring our system into the 21st century. And so you have more details in my written testimony. I'll stop there and just thank you for your time. I thank the BHA for their efforts, and please let me know if you have any questions. Thank you.
Thank you. We're going to move now to Larry Bram of Easter Seals.
Thank you for your time. I will be very quick today, as you saw in the written testimony. The governor has granted us a deficiency appropriation of $500,000 in FY21. He gave us $500,000 for our military family behavioral health clinic. That agreement required us to serve 103 clients, which we greatly exceeded. The current budget again grants us $500,000 for the same purpose. We've already seen 200 people in the first 7 months of the year, and we expect to reach 400. So due to COVID and the ending of the war in Afghanistan, the need for behavioral health services for veterans and their families has truly exploded. And so we hope you'll approve this deficiency appropriation. And then I will just wait for questions. Keep it quick.
Thank you. Mr. Dan Rabbit of BHSB.
Thank you, Chair Resnick, members of the committee. My name is Dan Rabbit. I'm a policy director at Behavioral Health System Baltimore. We're the local behavioral health authority for Baltimore City. Thank you for the opportunity to comment. To start, we want to thank the hardworking staff at Behavioral Health Administration for seeing us through these very difficult times. We support full funding of their budget and are appreciative of the rate increases and other investments included. It's especially important considering our very acute behavioral health workforce shortage situation right now. With that said, the evidence and the analysis that Andrew went over is absolutely on target, and it's alarming. The rate of fatal overdose increased 30% just last year, and it's gone up fourfold in the last decade. Metro Baltimore bears the brunt of these deaths, and increases in suicidal crisis, especially among our young people, is also on the rise and extremely troubling. We're in strong support of using the launch of the new National Suicide Prevention and Mental Health Crisis Hotline 988 as an opportunity to respond to these trends and help our struggling communities. A SAMHSA-funded analysis estimated that Maryland needed between $10 and $17 million to properly fund our network of local call centers in preparation of 988 launching in July. And so we're supporting HB 293, which would set up a trust fund to fund 988 call centers and other related crisis services with an initial $10 million investment. That $10 million investment, though, is for FY24, just because you can't deposit money in a trust fund until you've enacted the trust fund. And so we need dollars in FY23 as well. The analysis pointed out that there are some federal dollars. It's $2 million spread out over 2 years is all that's been made available so far, though. And we don't think that this is enough for our local call centers to be able to properly staff up. So we made a request to the governor that additional funds be included for 988 implementation in the budget. Those were not reflected. And so we hope that those funds may be provided in a subsequent supplemental, and appreciate any support that the General Assembly can provide in trying to make that happen. We want to second the need for ASO overpayment forgiveness. The ASO debacle has created serious challenges for all of our providers. We're seeing it in Baltimore all the time. On top of that, MDH has had payment issues as well. I know Chair Resnick, you brought this up in a previous hearing around MDH not being able to process invoices. So our providers are getting it every which way. And so overpayment forgiveness seems like a pretty reasonable mechanism to try to help them to respond to this increased need rather than having to make layoffs and close down services. Lastly, we just wanted to point out, we have some budget language that we're proposing in the DJS budget that the BHSB and our partners at the Children's Behavioral Health Coalition are proposing, but it does require significant collaboration with BHA. So we just wanted to mention it now. The language calls for a joint agency report on preventative programs to reduce youth detention and reduce incarceration of youth. And it's focused on youth-centered youth design models where their prevention programs are designed and developed by the youth they're intended to serve. So want to let you know about that. And besides that, I always really appreciate the opportunity to comment, and I'm happy to answer any questions folks might have.
Thank you, Dan. Where'd he go? Virtual. Next, we have Vicki Walters with the Maryland Association for the Treatment of Opioid Dependence.
Mr.
Hi,
Chairman,
good afternoon. Oh,
sorry. Mr. Chairman, do you mind if I ask Mr. Rabbit a question, or you just want to hold until all the witnesses?
Let's just hold until everybody speaks, and then we can.
Thank
Please
you.
go ahead, Ms. Walters.
okay, I'll be quick. Thank you.
No.
And good afternoon, Chair Resnick and members of the subcommittee. Speaking today as a representative of the Maryland Association for the Treatment of Opioid Dependence, which is a 65-member statewide organization of opioid treatment providers. And I'm also speaking as the executive director of a small nonprofit behavioral health program located in Baltimore City. I think that pretty much Lori summed it up pretty well in terms of we're asking that the subcommittee recommend a one-time use of the FY22 surplus for debt forgiveness for providers of the dollars that Optum says that we owe. As a small provider in the city, we have $87,000 is basically what we're told that we owe. But we are still waiting for over $65,000 in payments. As Lori said, there are lots of payments that have not been paid previously. And so I think that it's really critical that we look at forgiving this for providers in the community. We're stretched, we're stressed due to COVID, and we're seriously understaffed. And I think in that vein, we're also asking that you maintain the 3.25% provider rate increase, which was included in the governor's budget. As we struggle to fill positions across all areas in our programs, we're faced with increasing salaries for new hires, the high cost of necessary supplies, which has only been made worse by COVID and exacerbated by the current inflation happening across the supply chain. Additionally, we are so pleased that the budget finally includes dollars to reimburse peer support services in Maryland. Our peers provide a valuable service to the people that we serve, and as an integrated behavioral health system, we believe that the budget should include peer reimbursement for the entire behavioral health field, including mental health and not just SUD providers. Thank you for the opportunity to speak with you today.
Thank you. And last but definitely not least, we have Ms. Michelle Livshin from On Our Own Maryland.
Thank you, Mr. Chairman, Madam Vice Chair, and committee members for your dedicated service. And thank you to the administration for all of your hard work. I'm Michelle Livshin, Director of Network and Peer Services of On Our Own of Maryland. We're a behavioral health education and advocacy organization of peers, people with lived experience of mental health and substance use challenges. Our network of over 20 affiliated peer-run wellness and recovery centers, funded through the Behavioral Health Administration, offer free walk-in recovery support services to more than 5,000 Marylanders each year. For decades, our independent peer-run centers have been able to successfully reach community members with the greatest unmet needs, many of whom are unhoused, uninsured, and experience significant behavioral health challenges. At every center in our network, anyone can receive one-on-one peer support in groups, self-help tools, health education, and feel a sense of belonging that can literally mean the difference between life and death. Centers in our network achieve incredible outcomes despite operating on median budgets of less than $150,000 per year. Our peer-driven programs deliver services that meet the unique needs of their local communities. From our reentry program in Western Maryland to meal deliveries on the Lower Eastern Shore to housing support in Calvert County, we can be so innovative, flexible, and responsive because of the annualized funding we receive through BHA, and we dedicate every available dollar to direct services to the community. Peer support specialists are an integral component of the continuum of behavioral health care. We must continue to protect robust investment through grants for peer-led programs like ours that are able to reach individuals and communities most in need. and which cannot manage the complexity and unpredictability of billing through the fee-for-service system. Now is the ideal time to invest in grant-funded peer-run programs, not only because of the essential support we provide, but because we're training the next generation of certified peer recovery specialists and community leaders. Our peer network is ready to support our communities throughout the behavioral health crisis, but we must have adequate resources and funding to do so. We strongly urge the committee to vote in favor of full funding of BHA's FY23 budget. Thank you for my opportunity to speak.
Thank you. We will now take some questions, but before we do, Mr. Abbott, I did want to comment on something you said, this other issue about the backlog of invoices. I am still paying attention to that. I haven't dropped it. I believe in a previous hearing, Ms. Brandenburg had mentioned they wanted to the end of the month to be able to clear out all invoices, which I believe is what she had said last week. That would be on Monday. So I have it in my calendar. I will be calling her on Monday to get the status of that. And then we will go from there. But beyond that, any questions for this panel?
And much appreciated, Delegate. Chair Resnick.
Delegate Valentino Smith.
Thank you, and thank you, Mr. Chairman. Before I had a question for Mr. Rabbit and a question for Ms. Doyle. And before I start, I just want to say to Mr. Secretary, look, I know that things have been really rough for the department during COVID, and I know that I sound very frustrated in my questioning with respect to Optum. I know that you've devoted time and attention to it. It's just, it appears that it's not actually having the results each time that you expect Optum to be doing. So for Ms. Doyle, we talked a lot about the 9 months of estimated payments and reconciliation. And I think Delegate Resnick was leading into this. How's it going now with real-time adjudication of claims?
We're still having problems, and I will say that certain service lines have more problems than others. What I think strikes me most from what we hear from our providers is the amount of time it takes, back office, billing department time, to really follow a claim, make sure it's been paid, make sure it's been paid correctly, that there haven't been retractions that shouldn't have occurred. So it's just so very time consuming. And I think that's what's taking its toll on our provider network for current claims, that most of our providers have very small, I call them departments. They may be one person, two people. So it's very, very difficult to track. And we're just not used to this, since we've been in this kind of situation, ASO since 1997, and we've just never experienced anything like this before.
So there has been an ability for ASO to do this more efficiently. Mr. Chairman, just a minute here. Optum actually says on its website that it's the fastest growing part of United Healthcare, and it's a leading information and technology health services business, and that it delivers services through innovative partnerships and provides technology and tools that enabled unprecedented efficiency. So it doesn't sound like that's the case, but thank you, Ms. Doyle. Mr. Rabbit, you suggested some very compelling language that I think, were you asking for budget narrative between the DHS budget and the DMH budget for this juvenile services? Mm-hmm. Is it a pilot, and where is that language? Just so I'm clear on where the language is, so it doesn't get lost.
Sure. So the language is going to be in the DJS budget, but it directs BHA to collaborate with DJS on a report that reviews prevention efforts that are currently ongoing, models of youth-led and youth-designed prevention efforts around the country, and recommendations for what sort of prevention efforts might be most effective here in Maryland.
Thank you. So it sounds like you're working with one of the other chairs, Delegate Resnick and Vice Chair Chang are on. There'll be that coordination with the DJS budget. Thank you. Thank you, Mr. Chair.
Thank you. Any other comments or questions for this panel of witnesses? Seeing none, I believe that concludes our budget hearing today. Just going to point out to the members of the subcommittee, in addition to everyone who testified, there is additional written testimony in your packets from Carrie Cho at Cornerstone Montgomery, Lauren Grimes, CBH Maryland, Haley Rizkala at the Maryland Coalition of Families, and Regan Vaughn at Catholic Charities. So there's additional testimony that I think probably adds additional information to what has already been said here today. So we will, of course, take a look at that and read it. Besides that, I believe we are done for the day. When is our next budget hearing? June, can you remind me? Is June here? No? Okay, let me take a look. I believe we are on again for,
June is here.
oh,
One
hey,
second.
June. I got the information. Monday at 3 p.m. we will be meeting. It'll be the budget for the Department of Human Services, Family Investment Administration. So look forward to seeing everyone on Monday. And with that, we are adjourned. Thank you.